next speaker is Dr. Obaidur REHMAN. Will speak on auricular cartilage grafting for Entropio correction in cicatricial ocular surface pathologies.
Good morning, everyone. I'll be presenting the clinical profile and surgical technique with outcomes of auricular cartilage grafting for severe cicatricial entropion in ocular surface disorders. So chronic surface disorders, as we all know, lead to a host of different surface and eyelid abnormalities. And the posterior eyelid margin plays a very important role in maintaining the overall health of the ocular surface. But severe cicatrizing processes lead to posterior lamellar shortening and loss of tarsal integrity, which is a very severe complication in ocular surface pathologies. And chronic sequelae of ocular surface and eyelid may be seen in up to 90% in SJS patients. So there are already established procedures like eyelid margin MMG, which is quite popular, but it still gets negated when cicatricial entropion occurs because even after putting the eyelid MMG, there is constant rubbing of the ocular surface and irritation of the ocular surface. Further, any future surgery on the ocular surface, such as a cataract or a keratoplasty, will definitely require a stable surface. Single-stage entropion correction with mucous membrane graft is already described in literature, but when there is severe posterior lamellar shortening and loss of tarsal integrity, even such conventional procedures are not very helpful. So through this study, we want to describe the clinical profile, technique, and outcomes in severe cicatricial entropion with auricular cartilage graft as a corrective measure. So a retrospective EMR analysis was done to collect data where the primary outcome was restoration of eyelid position and the secondary outcome was the ocular surface staining score. This is the surgical technique which I'm showing you. So this is the eyelid everted and this is excision of the margin keratinization. After the margin keratinization is excised, there is a full thickness tarsotomy creation and a defect is created until entropion gets corrected. This defect is measured and now the posterior auricular surface is infiltrated. The skin and subcutaneous tissue is dissected to reach the auricular cartilage surface. And according to the dimensions of the defect, this cartilage graft is harvested. The surface is closed. This cartilage graft is now secured at the defect site with 6 vicryl absorbable sutures, as seen in this video. And finally, the eyelid margin is covered with the thin strip of mucous membrane, which is secured in place. At the end of the surgery, a bandage contact lens is placed. So in severe cicatricial entropion, when there is rubbing of the ocular surface and irritation, when we harvest this graft, and this graft is placed in position, it leads to lengthening of the posterior lamella, correction of the cicatricial entropion, and in turn it leads to the improvement of the ocular surface. So we enrolled 16 eyelids of 15 patients with no sex predilection, and we saw that the lower eyelid was involved more as it is less robust than the upper eyelid. SJS was the most common pathology, and simultaneous MMG was done in 5 eyelids. A mean follow-up of 16 months was carried out. So we achieved the primary outcome in 15 eyelids, that is 93% patients, and the secondary outcome, that was grading of the ocular surface improvement, was achieved in 10 eyelids. 81 patients improved subjective improvement in watering and photophobia after the procedure. 5 eyelids, after correction of 5 eyelids, patients could undergo successful cataract or keratoplasty surgeries and are doing well on follow-up. So this is what one of our patients who underwent bilateral procedures, and as you can see, the symptoms of photophobia and ocular surface irritation have improved. The ocular surface appears much improved here. In one patient, there was inadequate correction, which received further everting sutures, and cosmetic blemish, which can be seen, was present in 2 eyelids, but we saw no recurrence or mucosal ischemia or any corneal epitheliopathy in our study. So chronic cicatricial eyelid changes worsen the ocular surface, and when the cartilage graft is compared to various other available grafts, we see that it is easy to harvest. Its rigidity matches the tarsal plate. There is less donor side morbidity. However, there is one drawback, that it does not have a mucosal cover. So these are the various advantages of this graft, but the good thing is that epithelialization of the cartilage graft occurs within 2 to 4 weeks. And in our study also, we saw no patients of corneal epitheliopathy. So to conclude, auricular cartilage is a viable option in severe cicatricial entropion when the tarsal plate has lost its rigidity. It corrects the deformity as well as improves the ocular surface. And in the long term, we have seen satisfactory functional and cosmetic outcomes. Thank you.